Human memory is not a singular faculty, but a collection of interdependent systems, each responsible for different types of information, storage, retrieval, and processing. These systems are supported by distinct but interacting neural substrates. The primary classification of memory systems includes declarative, explicit, and non-declarative, implicit memory, each involving unique mechanisms and brain regions and retrieval of information. Declarative memory refers to the conscious recollection of facts and events, and is subdivided into episodic and semantic memory. Episodic memory enables individuals to remember specific personal experiences, such as a birthday party or a vacation, whereas semantic memory involves world information. The medial temporal lobe, mid, particularly the hippocampus, plays a central role in declarative memory. It acts as a temporary storage site for new information before it is gradually consolidated in neocortical areas for longer-term storage. The adjacent entorhinal, perihinal, and perihippocampal cortices support this system by processing different aspects of memory, such as object recognition and spatial context. Damage to the hippocampus, whether from trauma, hypoxia, or neurodegenerative disease, results in anterograde amnesia. The inability to store procedural or previously consolidated memories. This dissociation is exemplified by patient whose bilateral hippocampal resection abolished his ability to remember new experiences, yet left his intelligence and procedural memory intact. This case remains foundational in demonstrating the specialization of memory systems and their neural underpinnings. Semantic memory relies not only on the hippocampus, but also on distributed neocortical areas, particularly in the lateral temporal regions. Neuroimaging studies show that semantic knowledge retrieval activates a wide network, including the anterior temporal lobe, which appears to serve as a hub for integrating conceptual knowledge. In neurodegenerative conditions, like semantic dementia, patients exhibit profound loss of word meaning and conceptual understanding, underscoring the cortical basis of semantic memory. In contrast to declarative memory, non-declarative memory operates outside of conscious awareness and includes skills and habits, priming, classical conditioning, and non-associative learning. Procedural memory. A key component of this system involves the gradual acquisition of motor and cognitive skills, such as riding a bicycle or playing a musical instrument. This type of memory relies heavily on the basal ganglia and cerebellum The striatum, a major component of the basal ganglia, is particularly important for habit formation and sequence learning, while the cerebellum contributes to fine-tuning motor actions and timing, priming. Another form of implicit memory refers to the facilitated processing of a stimulus due to prior exposure. This phenomenon is often preserved in patients with amnesia, suggesting it is mediated by cortical structures separate from the cell. For example, visual priming is associated with activity in the occipital and fusiform cortices, while conceptual priming engages the prefrontal cortex. Working memory, often considered a distinct system from both declarative and non-declarative memory, involves the short-term maintenance and manipulation of information. It is critical for tasks such as reasoning, comprehension, and learning. The prefrontal cortex, particularly the dorsolateral prefrontal cortex, is a central hub for working memory operations. It coordinates attention and goal-directed behavior by interacting with sensory cortices and the parietal lobe, facilitating the temporary storage and processing of relevant information. The neural correlates of memory systems do not operate in isolation. Instead, they interact dynamically depending on task demands and learning stages. For instance, during skill learning, early performance may rely more heavily on declarative memory and hippocampal function, while with practice, control gradually shifts to the procedural memory systems. This interplay is supported by studies showing changing activation patterns in FRI over the course of training tasks. Emotion also modulates memory systems, often enhancing the consolidation of emotionally salient events. The amygdala, situated near the hippocampus, plays a crucial role in this process by modulating hippocampal activity during encoding and retrieval. This interaction explains why emotionally charged memories are often more vivid and enduring, though sometimes distorted. Understanding the architecture of memory systems and their neural substrates has profound implications for clinical practice and cognitive neuroscience. Memory impairments are among the most common and debilitating symptoms across neurological conditions, including Alzheimer's disease, Parkinson's disease, traumatic disorders, and psychiatric disorders, characterizing which memory systems are affected and which neural circuits are involved. Guides diagnosis, prognosis, and treatment planning, as well as the development of strategies. In essence, The study of memory is not merely about recalling the past, but about understanding the neural foundations of identity, learning, and adaptive behavior. Decision-making is a fundamental cognitive process that allows organisms to select actions from a set of alternatives based on goals, preferences, and environmental cues. It underlies nearly every aspect of human behavior, from routine choices to complex moral judgments. Advances in neuroscience have provided substantial insight into the neural mechanisms that support decision-making, revealing a distributed network of brain regions that integrate information and guide behavior. This neural circuitry operates across multiple cognitive domains, including perception, emotion, reward processing, and executive control. At the core of decision-making lies the prefrontal cortex, a highly evolved brain region critical for planning, reasoning, and goal-directed behavior. The dorsolateral prefrontal cortex, particularly involved in maintaining and manipulating information in working memory, comparing options, and exerting cognitive control. When faced with competing choices, the DOFC supports the evaluation of options by integrating sensory data and contextual information with internal goals. It is especially active during complex or ambiguous decisions, where deliberation and inhibition of automatic responses are required. The orbitofrontal cortex, the other subregion of the PC, plays a central role in value-based decision-making. It encodes the subjective value of potential outcomes, allowing the brain to weigh the costs and benefits of different actions. The OFT integrates sensory, emotional, and reward-related information to assign value to stimuli, a process that is essential for adaptive decision-making. For example, choosing between a healthy and an indulgent meal involves not only the nutritional content, but also the immediate and delayed rewards associated by the option. Closely linked to the OFD is the ventromedial prefrontal cortex, vindicated in evaluating options based on emotional significance and personal relevance. The VIMC is involved in encoding the expected value of a decision and integrating emotional responses into the decision-making process. Functional imaging studies have shown that activity in the VAMPHISI correlates with the perceived value of choices, particularly in scenarios involving social, morale, or financial judgments. Another critical component in decision-making is the basal ganglia, particularly the striatum. This subcortical structure is involved in reward learning and action selection through its role in processing prediction errors. The difference between expected and actual outcomes. Dopamine neurons in the midbrain, particularly the ventral tegmental area, vita and substantia nigra, project to the striatum and modulate its activity based on reward signals. When an outcome is better than expected, dopamine release increases, reinforcing the behavior that led to it. Conversely, negative prediction errors reduce dopamine signaling, discouraging unproductive actions. This reinforcement learning mechanism allows for the gradual optimization of decision-making strategies over time. The anterior cingulate cortex is another key structure involved in monitoring outcomes and adjusting behavior accordingly. It detects conflicts between competing responses, assesses the costs of exerting control, and signals the need for behavioral adaptation. The OXY is particularly active during difficult decisions and when outcomes deviate from expectations, making it essential for error detection and performance monitoring. Its interactions with the PFC and striatum support flexible decision-making in dynamic environments. Emotion and affective states also play a significant role in decision-making, often influencing judgments outside of conscious awareness. The amygdala, a limbic structure involved in processing emotions, contributes to the evaluation of threat, risk, and reward. It interacts with both cortical and subcortical areas to guide decisions, particularly in emotionally salient or high-stakes situations. In fear-based learning or aversive conditioning, for instance, the amygdala helps prioritize safety-related decisions that are critical for survival. The integration of these neural systems reflects the complexity of decision-making processes rather than occurring in a single brain region. Decision-making emerges from dynamic interactions across multiple circuits. These include cortical, subcortical loops that mediate different types of decisions, ranging from habitual to goal-directed behavior, and engage in feedback mechanisms that refine. Neuroscientific research into decision-making has profound implications for understanding both normal behavior and various clinical conditions. Impaired decision-making is a core feature of several psychiatric and neurological disorders, including addiction, obsessive compulsive disorder, and Parkinson's disease. These conditions often involve dysregulation in key decision-making circuits, such as altered dopamine signaling in the striatum or dysfunction in the prefrontal cortex. Understanding the neural basis of these impairments can inform therapeutic strategies and interventions aimed at restoring decision-making capacity. In conclusion, decision-making is supported by a complex, distributed neural network that integrates cognitive, emotional, and motivational information to guide behavior. Key structures such as the prefrontal cortex, striatum, amygdala, and anterior cingulate cortex work in concert to evaluate options, predict outcomes, and learn from feedback. This intricate neural architecture allows humans to make adaptive choices in an ever-changing environment, reflecting the sophisticated interplay between brain and behavior. Neuroplasticity, the brain's remarkable capacity to reorganize and adapt throughout life, is fundamental to the understanding of recovery from brain injury, once thought to be a fixed and immutable organ after early childhood. The adult brain is now recognized as a dynamic structure capable of generating new neural connections, modifying existing contexts, even generating new neurons. This adaptability becomes especially crucial in the context of injury, as it offers a biological basis for functional recovery and therapeutic intervention. Brain injuries, whether due to stroke, traumatic brain injury, PUI, or neurosurgical procedures, often result in the loss or impairment of specific cognitive, sensory, or location and extent of damage. Traditionally, such impairments were viewed as largely irreversible, particularly in adults. However, research over the past several decades has shown that through neuroplastic mechanisms, other regions of the brain can compensate for lost functions. This compensation may occur through several processes, including synaptic plasticity, dendritic sprouting, cortical remapping, and the unmasking of latent neural pathways. One of the most well-documented forms of neuroplasticity is the reorganization of cortical maps following injury. For instance, when the motor cortex area responsible for a particular limb is damaged, neighboring cortical regions may begin to assume control of that limb's movement. Functional magnetic resonance imaging studies have provided compelling evidence of such remapping, showing shifts in activation patterns over time as patients engage in rehabilitative activities. This reorganization is not random, but guided by activity-dependent mechanisms. Essentially, the brain strengthens neural pathways that are repeatable if use it, or lose it, or lose. A critical factor influencing neuroplastic recovery is timing. In the early days or weeks following injury, the brain enters a heightened state of plasticity, often referred to as a sensitive period, during which interventions such as physical therapy, contrast effects, animal models, and clinical studies suggest that this window represents a period of increased synaptic growth and rewiring potential, driven by elevated levels of neurotrophic factors like brain-derived neurotrophic factor. But the delayed rehabilitation, in contrast, may reduce the efficacy of plastic changes, underscoring the importance of early and intensive therapeutic efforts. Another essential consideration is the type of rehabilitation employed. Constraint-induced movement therapy, KINT for example, is a technique used primarily in stroke rehabilitation, where the unaffected limb is restrained, forcing use of the affected one. This not only encourages functional recovery, but has also been shown to produce measurable cortical reorganization. Similarly, mirror therapy and virtual reality-based interventions exploit the brain's visual and motor integration systems to drive plastic changes and facilitate recovery. Importantly, not all forms of neuroplasticity are beneficial. Maladaptive plasticity can occur, leading to the reinforcement of dysfunctional circuits. In chronic pain syndromes, for instance, persistent activation of pain pathways can lead to cortical reorganization that perpetuates the pain experience in post-stroke patients. Over-reliance on the unaffected hemisphere may interfere with optimal recovery by inhibiting activity in the damaged hemisphere. These phenomena highlight the need for targeted and personalized rehabilitation strategies that promote adaptive rather than maladaptive plasticity. These individual differences also play a significant role in neuroplastic potential and recovery outcomes. Factors such as age, lesion size and location, genetic predisposition, pre-injury cognitive reserve, and overall health status can influence the extent to which the brain can reorganize. Younger individuals generally exhibit greater neuroplastic capacity, although older adults are by no means incapable of recovery. Cognitive reserve, built through education, mental activity, and social engagement, has also been associated with more favorable outcomes, potentially by compensation. So, emerging research in neuromodulation techniques such as transcranial magnetic stimulation, TENS, and transcranial direct current stimulation, DDCs, offers additional avenues for enhancing neuroplasticity. These non-invasive methods aim to prime neural circuits for plastic change, either by exciting underactive areas or inhibiting hyperactive regions that interfere with recovery. When combined with traditional therapies, neuromodulation may amplify the brain's capacity for reorganization and functional improvement. In conclusion, neuroplasticity represents a cornerstone of modern neurorehabilitation. It transforms the narrative of brain injury from one of irreversible loss to one of dynamic potential, wherein the brain's capacity for change can be harnessed through evidence-based interventions. While the journey of recovery is often complex and individualized, the scientific understanding of plasticity offers a framework for hope, guiding clinicians and patients alike toward quality of life. Neuropsychological assessment tools are essential instruments in clinical and research settings for evaluating cognitive, emotional, and behavioral functioning. These tools are designed to identify strengths and weaknesses across various domains, such as memory, attention, language, executive function, visuospatial skills, and emotional regulation. They are widely used in diagnosing neurological and psychiatric conditions, planning treatment strategies, monitoring recovery or disease progression, and informing decisions related to educational and occupational accommodations. The utility of these tools, however, hinges on their validity. The extent to which they accurately measure the constructs they purport to assess. A neuropsychological battery typically consists of a series of standardized tasks administered under controlled conditions, allowing for comparisons to normative data derived from populations. Commonly used tests include the Wechsler Adult Intelligence Scale, WAS for General Cognitive Ability, the California Verbal Learning Test, VLUT for Verbal Memory, the Wisconsin Card Sorting Test, Thornton Test for Accension and Co. These instruments are interpreted alongside clinical interviews, behavioral observations, and collateral information to yield a comprehensive picture. The concept of validity in neuropsychological assessment is multifaceted. Construct validity refers to the degree to which a test measures the theoretical construct it is intended to assess. For example, a test designed to evaluate working memory must demonstrate that it does not simply tap into short-term storage, but also engages attentional control and manipulation of information. Convergent and discriminant validity are subtypes of construct validity. Convergent validity is established well with other measures of the same construct, while discriminate validity constructs, criterion. Related validity is another critical form, encompassing both predictive and concurrent validity. Predictive validity assesses how well a test forecasts future performance or outcomes, such as the ability of cognitive screening tools to predict functional decline in dementia. Concurrent validity evaluates the correlation between a test and an external criterion measured at the same time, such as the consistency between a new executive function task and an established gold standard measure. For instance, the Stroop test's concurrent validity may be assessed by comparing it with the Doberto test, as both tap into inhibitory control and cognitive flexibility. Teleological validity refers to the extent to which test performance reflects real-world functioning. This is especially important in neuropsychology, where the ultimate goal is to understand how cognitive deficits affect everyday life. Traditional tests conducted in artificial distraction free settings may not fully capture an individual's functional capacity. In response, newer assessments aim to improve ecological validity through the use of real-life simulations or virtual environments that better approximate. However, enhancing ecological validity must be balanced with the need for standardization and reliability. Another vital consideration is the cultural and linguistic validity of neuropsychological assessments. Tests developed and normed in Western populations may not be appropriate for individuals from different cultural backgrounds due to biases in language, tutoring behavior. Cross-cultural validity requires that tests be adapted through careful translation, back translation, and cultural contextualization, followed by renorming in the target population. Without these steps, the risk of misdiagnosis or inappropriate interpretation increases significantly. The validity of neuropsychological tools also depends on the quality of normative data and the control of extraneous variables. Age, education, socioeconomic status, and ethnicity can all influence test performance and must be accounted for during interpretation. Normative databases that stratify results by these demographic variables improve diagnostic accuracy and reduce false positives or negatives. While individual tests can offer valuable insights, the integration of findings across multiple tools enhances validity by inconsistent patterns or sparring across domains. For example, a pattern of poor performance on memory tests, accompanied by intact language and visuospatial function. Mild cognitive impairment. Conversely, scattered deficits across tests without a coherent profile may suggest suboptimal effort, emotional interference, or non-neurological factors. To ensure valid results, clinicians must also consider test administration conditions and patient variables such as fatigue, motivation, medication effects, and psychiatric symptoms. Performance validity tests, PVs, are increasingly included in assessment batteries to evaluate the credibility of test performance. These tools help distinguish between genuine cognitive impairment and poor effort or exaggeration, which is especially important in medico, legal or disability evaluation contexts. In conclusion, neuropsychological assessment tools are powerful methods for understanding brain-behavior relationships, guiding diagnosis, and shaping interventions. Their validity, spanning construct, criterion, ecological, and cross-cultural domains, is crucial to their effectiveness. Ongoing research, normative refinement, and the methodological innovations continue to enhance the precision and applicability of these assessments, ensuring they remain central to clinical neuroscience and psychological practice. Substance abuse exerts profound neuropsychological effects, with consequences that span cognitive, emotional, and behavioral domains. The impact varies depending on the substance, duration, and intensity of use, individual vulnerability, and coexisting mental. However, common threads run through the neuropsychological profiles of substance abusing individuals, including impairments in attention, memory, executive function, and emotional regulation. These deficits reflect the underlying alterations in brain structure and function caused by chronic exposure to psychoactive substances, posing challenges to rehabilitation and reintegration. The brain's reward system, particularly the mesolimbic dopamine pathway, involving the ventral tegmental area, VTAR, and nucleus accumbens, plays a central role in the development of substance dependence. Most addictive substances, whether stimulants like cocaine and methamphetamine, depressants like alcohol, or opioids like heroin, increased dopamine availability, directly and indirectly reinforcing drug taking. Repeated stimulation of this system leads to neuroadaptive changes, including receptor downregulation and altered neurotransmitter dynamics, which can diminish sensitivity to natural rewards and increase compulsive drug seeking. Chronic substance use also disrupts the prefrontal cortex, a region critical for executive functions such as decision-making, impulse control, and working memory. This frontal lobe dysfunction is a hallmark of many substance use disorders and contributes to poor judgment, increased risk. Taking and DeFeo, for instance. Neuroimaging studies consistently show reduced gray matter, volume, and hypoactivity in the prefrontal regions of individuals addicted to alcohol, stimulants correlating with their diminished cognitive flexibility and planning ability. Memory impairments are another prevalent neuropsychological consequence of substance abuse. Long-term alcohol use is particularly associated with damage to the hippocampus and diencephalic structures, resulting in difficulties with encoding new information and forming long-term memories. In extreme cases, thiamine deficiency in alcohol dependent individuals leads to Wernicke-Korsakoff syndrome, a severe amnestic condition marked by confusion and profound anterograde. Stimulants such as methamphetamine can also induce neurotoxic effects on hippocampal and cortical neurons, impairing both verbal and spatial memory. Attention and processing speed are frequently compromised across multiple substance categories. Cocaine users often exhibit deficits in sustained attention and reaction time, while cannabis users may show impaired short-term memory and attentional filterings. Even after these disruptions reflect alterations in dopaminergic and glutamatergic neurotransmission, as well as structural changes in cortical circuits. Notably, adolescents who engage in early and heavy drug use are particularly vulnerable, as their developing brains are more susceptible to neurotoxic damage, leading to long-term cognitive consequences. Emotion regulation and affective processing are also significantly impaired in substance-dependent populations. Chronic use of depressants, like alcohol and benzodiazepines, can blunt emotional responsiveness and increase irritability or mood instability. Conversely, stimulants may initially induce euphoria, but ultimately contribute to anxiety, paranoia, or aggression due to dysregulated monoamine systems. Neuropsychologically, these emotional dysregulations are linked to impaired connectivity between the amygdala and prefrontal cortex, disrupting the balance between emotionally downregulated polysubstance use, and comorbid psychiatric disorders further complicate the neuropsychological picture. Many individuals with substance use disorders also suffer from depression, anxiety, PTSD, or schizophrenia, conditions that themselves carry cognitive burdens. The bidirectional relationship between psychiatric illness and substance use creates a challenging clinical landscape in which causality is difficult to disentangle, and neurocognitive impairments are often more severe and persistent. Rehabilitation from substance abuse requires addressing both the behavioral and neurocognitive sequelae of addiction. Cognitive remediation therapy, mindfulness-based interventions, and pharmacological agents targeting neurotransmitter imbalances have shown promise in improving executive function and emotional regulation. Importantly, neuropsychological recovery is not uniform. While some cognitive functions may recover with sustained abstinence, others, particularly those linked to structural brain damage, may remain impaired. Understanding the specific neuropsychological profiles associated with different substances can inform tailored interventions that maximize cognitive recovery and abstinence. In sum, substance abuse leads to widespread and often enduring changes in brain function, manifesting in cognitive deficits, emotional disturbances, and impaired self-control. These changes are rooted in the neurotoxic effects of substances on key brain regions and circuits, particularly those governing reward, memory, and executive control. A comprehensive approach to treatment must therefore integrate neuropsychological assessment and rehabilitation as essential components of substance use disorders. Epilepsy is a chronic neurological disorder characterized by recurrent, unprovoked seizures resulting from abnormal electrical activity in the brain. While seizures are the most visible manifestation of epilepsy, the condition is frequently associated with a wide range of neuropsychological sequelae that significantly impact cognitive, emotional, and behavioral functioning. These effects can vary depending on the type, frequency, and location of seizures, as well as the underlying etiology. Age of onset history. Neuropsychological impairments in epilepsy are not merely consequences of seizure activity, but also reflect broader disturbances in brain networks, comorbid conditions, and treatment effects. Cognitive impairments are among the most prominent and disabling consequences of epilepsy. Memory dysfunction is particularly common, especially in individuals with temporal lobe epilepsy. The most prevalent focal epilepsy syndrome in adults the temporal lobes, particularly the hippocampus and surrounding medial structures, are essential for declarative memory formations. Repeated seizures, hippocampal sclerosis, or surgical resection in this region can result in significant deficits in episodic memory, affecting the ability to form, store, and retrieve personal experiences. Verbal memory deficits are typically more pronounced in left Lee, while right often affects visual and spatial memory. These memory problems can persist even between seizures and significantly interfere with academic, occupational, and social functioning. Attention and executive function are also commonly affected in epilepsy, particularly in those with generalized seizures or frontal lobe involvement. Individuals may experience reduced sustained attention, slower information processing speed, impaired cognitive flexibility, and poor planning or problem-solving abilities. These deficits are often exacerbated by interictal epileptiform discharges, abnormal brain activity that occur in seizures, and may be present with well-controlled seizure frequency. Executive dysfunction is especially problematic in children with epilepsy, where it can interfere with educational progress and social development. Language deficits can occur in epilepsy, depending on the location of the epileptogenic focus. Left hemisphere epilepsy, particularly in parasylvian areas, may result in expressive or receptive language impairments, difficulty finding words, including and impaired comprehension. In children, frequent seizures during critical developmental periods can disrupt normal language acquisition and literacy skills. Furthermore, repeated seizures and ongoing interictal activity may lead to cumulative cognitive deficits, which is especially concerning in treatment-resistant cases. Emotional and psychiatric comorbidities are highly prevalent in individuals with epilepsy and often interact with cognitive impairments. Depression, anxiety, and irritability are common and may be related to the psychosocial impact of living with a chronic illness, as well as direct effects of emotional dysregulation can further impair cognitive function by reducing motivation, concentration, and processing efficiency. Additionally, certain epilepsy syndromes, such as temporal lobe epilepsy, have a higher association with mood disorders due to their involvement with emotional processing centers in the brain. Anti-epileptic drugs, AEDs, while essential for seizure can also influence neuropsychological function. Some older medications, such as phenobarbital or topiramate, are known to cause sedation, slowed thinking, and memory impairment. Newer agents generally have a more favorable cognitive profile, but therapy at high dosages can still result in adverse effects. Balancing seizure control with cognitive side effects is a central challenge in epilepsy management, highlighting the need for individualized treatment plans. In pediatric populations, epilepsy presents unique neuropsychological challenges. Early onset seizures, especially in infancy or early childhood, can disrupt brain development and lead to widespread cognitive delays. Epileptic encephalopathies, such as Lennox, Gastaut syndrome, or Dravet syndrome, are associated with severe intellectual disability, language impairment, even in less severe cases. Children with epilepsy are at increased risk for attention deficit hyperactivity disorder, adult learning disabilities, and social difficulties. Early assessment and intervention are critical in mitigating long-term cognitive and developmental consequences. Neuropsychological assessment plays a vital role in the comprehensive evaluation of individuals with epilepsy. Standardized testing can identify specific cognitive strengths and weaknesses, inform treatment decisions, and guide educational or occupational accommodations. In pre-surgical evaluations, such assessments help determine cognitive risks associated with epilepsy surgery, such as potential memory decline following temporal lobectomy. Post-surgical follow-up can then track cognitive outcomes and rehabilitation needs. In conclusion, epilepsy extends far beyond the occurrence of seizures and encompasses a wide spectrum of neuropsychological sequelagical. These include impairments in memory, attention, executive function, language, and emotional regulation, all of which can significantly affect quality of life and daily functioning. Understanding the cognitive and psychological dimensions of epilepsy is essential for holistic care, requiring collaboration between neurologists, neuropsychologists. Through comprehensive assessment and tailored intervention, it is possible to improve cognitive outcomes and support the overall well-being of individuals living with epilepsy. Sleep is an essential neurobiological process that plays a critical role in maintaining cognitive, emotional, and physiological health. The field of neuropsychology investigates how sleep contributes to brain function, as well as how disruptions in sleep architecture can lead to various neurological and psychological disorders. Understanding the neuropsychology of sleep involves examining the brain regions, neurotransmitter systems, and functional processes that regulate sleep, as well as the cognitive and behavioral outcomes of sleep abnormality. Sleep is not a uniform state, but a dynamic cycle composed of rapid eye movement. REM sleep, which is further divided into stages none through 3. Each stage is associated with distinct patterns of neural activity, and together they facilitate memory consolidation, emotional regulation, and metabolic homeostasis. REM sleep, especially slow-wave sleep, SWOS or stage 3, is primarily involved in the consolidation of declarative memories and the clearance of metabolic waste from the brain via the glymphatic system. REM sleep, on the other hand, is associated with vivid dreaming, emotional memory processing, and the consolidation of procedural and spatial memories. These sleep phases are orchestrated by a complex interplay of brainstem nuclei, the hypothalamus, and cortical networks. Central to sleep regulation are two biological processes: the circadian rhythm, governed by the suprachiasmatic nucleus, scan of the hypothalamus, which accumulates during wakefulness. Neurotransmitters such as gamma, aminobutyric acid, GABA, norepinephrine, acetylcholine, and orexin modulate transitions between sleep and wakefulness. For instance, GABA promotes sleep by inhibiting wake, promoting neurons in the hypothalamus and brainstem, whereas orexin stabilizes wakefulness and prevents inappropriate transitions into REM sleep. When sleep is disrupted, whether due to lifestyle factors, psychological conditions, or neurological abnormalities, it can lead to significant cognitive and affective impairments. Sleep disorders such as insomnia, obstructive sleep apnea, also narcolepsy, restless leg syndrome, sleep wake disorders reflect disruptions and have distinct neuropsychological profiles. For example, individuals with insomnia often experience hyperarousal and difficulty initiating or maintaining sleep. Working memory and emotional regulation. Functional imaging studies show increased activity in the default mode network, DIN, and decreased prefrontal cortex activity in insomnia, correlating the function and executive dysfunction. Obstructive sleep apnea. characterized by repeated episodes of airway obstruction during sleep, results in intermittent hyperventilation. This leads to deficits in vigilance, memory, and executive function, and is associated with structural changes in prefrontal cortex. Long-term untreated also has been linked to an increased risk of neurodegenerative diseases, including Alzheimer's diseases, likely due to chronic hypoxia and impaired glymphatic proteins. Narcolepsy, particularly type 1, is a hypersomnia disorder caused by a deficiency of orexin, producing neurons in the hypothalamus. It is marked by excessive daytime sleepiness, cataplexy, sleep paralysis, and disrupted nocturnal sleep. From a neuropsychological perspective, narcolepsy results in problems with sustained attention and episodic memory, and can severely affect quality of life due to social and occupational impairments. Neuroimaging often reveals abnormalities in hypothalamic and limbic structures, underscoring the disorder's neurological basis. Restless legs syndrome, another sensorimotor sleep disorder, involves uncomfortable sensations in the limbs accompanied by interfering with sleep initiation. Though the pathophysiology is not fully understood, it may involve dysfunction in dopaminergic pathways and iron metabolism in the central nervous system. In the central nervous system, neuropsychological consequences include fatigue-related cognitive slowing and irritability, which may be underappreciated but significantly impact daily functioning. Sleep disturbances also play a central role in many psychiatric disorders. Depression and anxiety are frequently accompanied by insomnia or hypersomnia, and sleep abnormalities often precede the onset of mood episodes. Sleep deprivation exacerbates emotional dysregulation and cognitive impairments, creating a vicious cycle that complicates it. Moreover, disruptions in REM sleep are particularly implicated in affective dysregulation and trauma-related disorders such as experience, REM fragmentation, and nightmares. The bidirectional relationship between sleep and brain function suggests that improving sleep quality can yield measurable benefits in neurocognitive performance and mental health. Cognitive behavioral therapy for insomnia, continuous positive airway pressure (CPAP). For sleep apnea, pharmacological agents for narcolepsy and ROLS, and light therapy for circadian rhythm disorders, and memory and mood. Emerging research in sleep neuropsychology continues to explore how targeted modulation of sleep architecture, such as enhancing sleep well-being, might. In sum, sleep is a foundational pillar of neuropsychological health, intricately connected to virtually every domain of brain function. Disruptions in sleep architecture and quality can lead to widespread impairments, from attention deficit to mood disturbances, and are implicated in the pathophysiology of numerous neurological and psychiatric conditions. As such, sleep should be viewed not merely as a restorative state, but as an active neurobiological process essential for the optimal functioning of the human mind. Would you like a version of this essay with academic citations included for each claim? Prosopagnosia, commonly known as face blindness, is a neurocognitive disorder characterized by the impaired ability to recognize faces. This condition can range from difficulty distinguishing unfamiliar faces to the complete inability to recognize familiar individuals, including one's own reflection. It provides a compelling window into the specialized mechanisms of human face perception and the modular organization of the visual and associative cortices. While face recognition might appear effortless in daily life, prosopagnosia underscores the complexity and specificity of this cognitive function. Face recognition engages a distributed network of brain regions, but the fusiform face area, FA, located in the fusiform gyrus of the inferior temporal lobe, is considered the central hub. Functional neuroimaging studies have consistently demonstrated robust activation of the FA when individuals view faces, as opposed to other objects or stimuli. Prosopagnosia arises when this area or its connections are disrupted, either due to acquired brain injury, typically from stroke, head trauma, or neurodegeneration, or through congenital developmental differences. In acquired prosopagnosia, lesions are usually localized to the right occipitotemporal region, particularly involving the FA and adjacent areas such as the occipital face area and the superior temporal sulcus. These regions work in concert to detect facial features, encode configural relationships. The spacing between features, and interpret dynamic cues like expression and gaze direction. Damage to these circuits can impair both perceptual processing and memory-based recognition of faces. In contrast, developmental prosopagnosia occurs in the absence of obvious brain injury or structural anomalies, suggesting a disruption in a maturation. processing network. DIP is believed to have a heritable component, with familial clustering observed in many cases. Importantly, prosopagnosia is face-specific. Most individuals retain normal vision, intelligence, places, or even non-facial body cues. This selectivity supports the hypothesis that face processing relies on dedicated neural mechanisms, rather than being a subset of general visual recognition. Behavioral experiments demonstrate that face recognition is predominantly holistic and configural, relying on the spatial relationships among facial features rather than isolated attributes. Prosopagnosic individuals often rely on compensatory strategies, such as using voice, hairstyle, or distinctive clothing to identify others. Though these methods are far less efficient and socially intuitive, the clinical manifestations of prosopagnosia can have profound psychosocial effects. Affected individuals may experience embarrassment, social withdrawal, or anxiety due to their difficulties in navigating everyday interpersonal interactions. In severe cases, it may be difficult to recognize close family members, or even oneself, in photographs or mirrors. Children with developmental prosopagnosia may face challenges in school and social settings, often being mislabeled as inattentive or socially avoidant because awareness of the condition remains limited. Many people go undiagnosed or are misdiagnosed with social anxiety or autism spectrum disorder. Diagnosis of prosopagnosia relies on detailed neuropsychological assessment, including tests like the Cambridge Face Memory Test, Seefold and Benton Facial Recognition Test, which evaluate the to learn, recognize. Functional memory can aid in visualizing underactivation in face selective regions during facial recognition tasks. For acquired cases, structural imaging often reveals focal damage to the right fusiform gyrus or connecting white matter, such as the inferior longitudinal fasciculus. Eye tracking studies further indicate that prosopagnosic individuals often focus abnormally on less informative facial regions, such as the mouth or ears, rather than the eyes or nose. Currently, there is no definitive cure for prosopagnosia, though several therapeutic approaches are under investigation. Cognitive training programs aimed at improving perceptual discrimination, memory for facial features, or attention to key facial areas have shown modest success, especially in children with dysagnosia. Assistive technologies including facial recognition apps, are increasingly used as compensatory tools. Moreover, educating family, educators, and colleagues about the condition can help reduce stigma and enhance supportive social environments. From a neuroscientific perspective, prosopagnosia affirms the existence of domain-specific processing within the brain and raises intriguing questions about the neuroplasticity and limits of functional reorganization. The dissociation between face and object recognition capabilities supports the theory of a dedicated cognitive module for facial processing, finely tuned through evolution for recognition. Studying prosopagnosia not only enhances our understanding of visual cognition, but also informs broader principles about brain specialization and the interdependence of perceptual identity. Parkinson's disease is a progressive neurodegenerative disorder primarily recognized for its motor symptoms, such as tremor, rigidity, bradykinesia, and postural instability. However, beyond its hallmark motor disturbances, Parkinson's disease also involves significant non-motor features, including a distinctive neuropsychological profile characterized by cognitive and emotional changes. These cognitive impairments are increasingly recognized as central components of the disease, often impacting quality of life, functional independence, and treatment outcomes. The neuropsychological manifestations of Parkinson's disease are diverse, reflecting the widespread involvement of cortical and subcortical brain regions. Early disease course. Many patients experience mild cognitive impairment, McKee, which may remain stable or progress to Parkinson's disease dementia. In later stages, the cognitive deficits typically observed in Parkinson's are not uniform but tend to follow patterns associated with disruptions in fronto-circuital cortex with the basal ganglia. These circuits are crucial for executive function, attention, and working memory, and their dysfunction underpins many of the cognitive features of the disease. Executive dysfunction is one of the most prominent cognitive impairments in Parkinson's disease. Patients may have difficulty with planning, organizing, problem solving, set, shifting, and inhibiting inappropriate responses. These deficits can manifest in everyday challenges, such as difficulty multitasking, poor decision-making, or trouble adapting to changing circumstances. Such impairments are typically linked to dopamine depletion in the basal ganglia, which disrupt the function of the prefrontal cortex. Dopaminergic medications, such as levodopa, can improve some executive symptoms, though their effects on cognition are less consistent than on motor symptoms. Attention deficits are also common in Parkinson's disease, especially in tasks that require sustained concentration or rapid shifting of focus. Patients may be easily distracted, take longer to process information, or struggle in environments with multiple competing stimuli. These attentional impairments can exacerbate memory complaints, as effective encoding and retrieval rely on intact attention mechanisms. Unlike in Alzheimer's disease, memory deficits in Parkinson's are often retrieval-based rather than encoding-based. Patients may benefit from cues or structured prompts, indicating that information is stored but not readily accessible due to disrupted hippocampal connectivity. Visuospatial dysfunction is another notable feature, often present even in early stages of Parkinson's disease. Patients may have difficulty judging distances, navigating unfamiliar environments, or interpreting complex visual scenes. These problems are associated with posterior cortical and parietal lobe involvement, and are particularly concerning because they contribute to falls, impaired driving ability, and difficulties such as dressing or cooking. Visuospatial impairments can also predict conversion to dementia in Parkinson's, serving as an early warning sign of more global cognitive decline. Language abilities are generally preserved in Parkinson's disease, especially at the level of syntax and grammar. However, subtle deficits in verbal fluency are common. Patients may struggle with tasks requiring the rapid generation of words, especially those beginning with a specific letter. Phonemic fluency. This reflects executive dysfunction rather than a core language disorder, and often co-occurs with bradyphrenia, slowed cognitive processing that can affect conversation, that can affect times in later stages. Up to 80% of individuals with Parkinson's develop Parkinson's disease dementia. PUD, a condition characterized by widespread cognitive decline that interferes with daily functioning. It includes more severe impairments in attention, executive function, memory, and visuospatial skills, often accompanied by neuropsychiatric symptoms such as hallucinations, apathy, and mood disturbances. The pathology underlying PUD involves not only dopaminergic loss, but also cholinergic deficits and the spread of Lewy body pathology to cortical areas. The neuropsychological profile of PUD overlaps significantly with dementia, with Lewy bodies, and differentiating the two often relies on the timing of cognitive and motor symptom onset. emotional and behavioral changes are integral to the neuropsychological profile of Parkinson's disease. Depression, anxiety, and apathy are common and may precede motor symptoms. These affective symptoms can exacerbate cognitive deficits and complicate clinical management. Additionally, impulse control disorders, including compulsive gambling, shopping, or eating, may emerge in patients receiving dopamine agonists, highlighting the role of dopamine in regulating band behavior. Assessment of cognitive function in Parkinson's disease relies on comprehensive neuropsychological evaluation, which helps distinguish between normal aging, mixed, and dementia. Standardized tools, such as the Montreal Cognitive Assessment, MoCA, along with domain specific tasks assessing executive function, attention, and visuospatial ability, are crucial for accurate diagnosis and management planning. Interventions may include cognitive rehabilitation, pharmacological treatments, such as cholinesterase inhibitors, and psychosocial support aimed at improving functional outcomes and caregiver well-being. In conclusion, Parkinson's disease encompasses a complex neuropsychological profile that extends well beyond its motor symptoms. Cognitive impairments, particularly in executive function, attention, and visuospatial processing, are early and significant contributors to disease burden. As the disease progresses, these cognitive changes may evolve into a more global dementia, often accompanied by behavioral and emotional symptoms. Understanding and addressing these cognitive dimensions are essential for holistic management and improving the overall quality of life for individuals living with Parkinson's disease. For much of modern neuroscience, the cerebellum has been chiefly associated with motor control, specifically the coordination, precision, and timing of movement. However, over the past few decades, a growing body of evidence has radically expanded our understanding of this densely packed structure, revealing its significant role in cognitive processes. Despite occupying only about 10% of the brain's volume, the cerebellum contains more than half of its neurons, suggesting a computational capacity far beyond motor regulation. Anatomical, clinical, and functional studies now consistently demonstrate that the cerebellum contributes to a wide array of non-motor functions, including attention, language, executive function, and even social cognition. The expansion of this view began with neuroimaging studies and clinical observations. Patients with isolated cerebellar lesions often present not only with movement abnormalities, constellation of symptoms now termed cerebellar cognitive affective syndrome. This syndrome includes deficits in planning, abstract reasoning, working memory, linguistic processing, and emotional regulation. Such symptoms occur even when motor functions are relatively spared, indicating that the cerebellum has functionally distinct roles in cognition. Moreover, functional memory studies have repeatedly shown activation in cerebellar regions during tasks that require no motor output, such as verbal fluency, problem solving, and attentional switching. The key to understanding the cerebellum's cognitive role lies in its extensive connectivity. It forms closed loop circuits not only with motor areas of the cerebral cortex, but also with prefrontal, parietal, and temporal association areas, regions deeply involved in cognition. These loops follow the same topographical principles as the motor circuits, but target different cerebellar zones, especially the lateral hemispheres and the posterior lobe. For instance, connections between the lateral cerebellum and the dorsolateral prefrontal cortex are implicated in working memory and executive control. While circuits linking and reasoning, the underlying mechanism through which the cerebellum contributes to cognition, is believed to mirror its role in motor control, prediction, error correction, and the optimization of. In motor tasks, the cerebellum predicts the sensory consequences of an action and refines movement through feedback. Similarly, in cognitive tasks, it may generate predictions about sequences, linguistic constructions, refining mental operations via feedback from cortical partners. This makes the cerebellum especially important in domains that require fluid integration of information over time, such as language comprehension, problem solving. Language offers a particularly compelling example of cerebellar involvement in cognition. The right posterior cerebellum, which is functionally connected to left hemispheric language areas, becomes active during verbal working memory and syntactic processing. Lesions in these areas can lead to problems with verbal fluency, grammar construction, and even comprehension. Unlike classical aphasias, these language impairments often present subtly, with the patient aware of difficulty in organizing thoughts or maintaining the pace and rhythm of speech, rather than producing outright semantic errors. Executive functions, another cornerstone of human cognition, also depend on cerebellar input. Tasks that demand mental flexibility, inhibition of prepotent responses, and goal directed behavior have been shown to recruit cerebellar circuits, particularly those connected with the prefrontal cortex. Patients with cerebellar damage may struggle with multitasking, decision-making, or adapting to novel situations, not because of impaired reasoning per se, but due to difficulty in managing the sequencing and coordination of thought. Interestingly, the cerebellum is also implicated in affective and social cognition. Individuals with cerebellar pathology may exhibit emotional blunting, poor affect regulation, or impaired theory of mind. The ability to infer others' mental states. These findings further broaden the scope of cerebellar function, suggesting a role in predicting and interpreting not only physical, but also social events. Finally, developmental studies reinforce the cerebellum's importance in cognitive growth. Early cerebellar injury is associated with long-term deficits in attention, language, and executive function, often exceeding the impact of similarly timed cortical lesions. This suggests the cerebellum may act as a scaffolding system for developing neural circuits, guiding the maturation of higher-order cognitive functions. The cerebellum's role in cognitive tasks is thus far more substantial and nuanced than once believed. Far from being a purely motor structure, it serves as an integrative hub, coordinating mental processes with the same precision and adaptability it brings to movement. As research continues to unpack the cerebellum's diverse connections and computational strategies, it is likely to yield deeper insights into not only typical cognitive function, but all psychiatric conditions where these functions go awry. Stroke is a leading cause of adult disability worldwide and has profound effects not only on motor and sensory function, but also on cognitive performance. While the physical consequences of stroke, such as hemiparesis or speech impairments, are often more visible, cognitive deficits are equally prevalent and can significantly impact quality of life. These deficits vary widely depending on the location, type, and severity of the stroke, as well as individual patient factors such as age, education, and pre-existing cognitive reserve. A stroke occurs when the blood supply to a part of the brain is interrupted, either by a blockage, ischemic stroke, or a rupture of a blood vessel. Hemorrhagic stroke, leading to brain cell damage or cognitive impairment, result when these vascular events affect areas involved in attention, memory, executive functioning, language, or visuospatial processing. The pattern and severity of cognitive dysfunction depend on the specific brain regions impacted, with some areas more closely tied to particular domains of cognition. Attention deficits are among the most commonly reported cognitive impairments following stroke. These may include difficulty sustaining focus, dividing attention between tasks, or shifting attention appropriately. Strokes affecting the frontal lobes, parietal lobes, or thalamus can lead to significant attentional disturbances. For example, right hemisphere strokes often result in neglect syndrome, where the patient fails to attend to stimuli on the left side of space, profoundly affecting daily function. Memory impairment is another frequent outcome of stroke, particularly when the medial temporal lobes, hippocampus, or thalamic regions are involved. Thalamic regions are involved. Patients may struggle with encoding new information, retaining learned material, or retrieving past events. In contrast to degenerative memory loss, seen in conditions like Alzheimer's disease, post-stroke memory deficits often have a more abrupt onset and may be more selective, sometimes sparing semantic memory while lacking memory. Furthermore, memory impairments in stroke survivors are often intertwined with deficits in attention and executive function, as these systems work synergistically during and retrieval. Executive dysfunction is especially common after strokes involving the prefrontal cortex or its subcortical connections. These impairments can include difficulties in planning, organizing, problem solving, initiating tasks, and inhibiting inappropriate behaviors. Such deficits are often subtle, yet have a profound impact on everyday life, affecting medication adherence and its financial management and social interactions. Patients may appear apathetic or disorganized, and their ability to adapt to new situations or follow through with complex tasks may be diminished. Language disturbances, known as aphasia, occur most frequently with left hemisphere strokes, particularly those involving the parasylvian region. Depending on the specific area affected, individuals may experience Broca's aphasia, non-fluent, effortful speech, Wernicke's aphasia, fluent but nonsensical speech with poor comprehension, or global aphasia, severe impairment, and both action and comprehend. Language deficits can significantly hinder communication and contribute to social isolation, making speech Language therapy, a crucial aspect. Visuospatial impairments, typically associated with right hemisphere damage, affect the ability to perceive spatial relationships, navigate environments, or manipulate objects. These difficulties can manifest as problems dressing, finding one's way, or even recognizing familiar faces. When severe, they contribute to safety risks and limit independence, particularly in unfamiliar environments. In addition to these domain-specific deficits, many stroke survivors experience slowed processing speed and reduced mental stamina, often referred to. These issues can hinder performance across cognitive tasks and are particularly problematic in rehabilitation settings, where sustained mental effort is required for recovery. They also compound other deficits, making even simple daily tasks cognitively demanding. Emotional and behavioral changes frequently co-occur with cognitive impairments. Depression, anxiety, and emotional lability are common post-stroke and can further impair cognition by affecting motivation, attention. Moreover, the interaction between mood and cognition is bidirectional, meaning that cognitive impairment can exacerbate emotional distress and vice versa. Recovery from cognitive impairments post-stroke varies. Some patients experience significant improvement, especially in the first 6 months, while others continue to struggle with chronic deficits. Neuroplasticity, the brain's ability to reorganize and form new connections, plays a critical role in recovery. Rehabilitation strategies often involve cognitive training, compensatory techniques, environmental modifications, and caregiver education. Early intervention and individualized, goal-directed therapy can optimize outcomes. In conclusion, stroke has a multifaceted impact on cognitive function, affecting attention, memory, executive abilities, language, and visuospatial skills. These impairments can be as disabling as physical deficits and require comprehensive assessment and targeted rehabilitation. Understanding the cognitive consequences of stroke is essential for holistic patient care and for supporting long-term recovery and reintegration into daily life. Chronic stress exerts profound and multifaceted effects on brain function, influencing cognition, emotional regulation, and long-term neurological health. While stress is an adaptive response evolved to manage acute threats, persistent activation of the stress response system can be maladaptive. The primary mediators of the stress response, glucocorticoids such as cortisol, catecholamines like norepinephrine, and inflammatory cytokinase, alter neural circuitry. These alterations are especially pronounced in brain regions critical for learning, decision making, and emotional regulation, including the hippocampus and amygdala. At the neurobiological level, chronic stress disrupts the hypothalamic, pituitary, adrenal axis, leading to prolonged elevations in glucocorticoids. The hippocampus, a key structure for episodic memory and spatial navigation, is densely populated with glucocorticoid receptors, making it particularly susceptible to stress-induced damage. Prolonged cortisol exposure reduces dendritic branching and neurogenesis in the hippocampus, impairing synaptic plasticity, the brain's ability to adapt and form new connections. These structural changes translate into observable deficits in memory, formation, and retrieval. Animal studies have shown that rodents exposed to chronic stress perform poorly on tasks involving spatial learning, with corresponding reductions in hippocampal volume. The prefrontal cortex, responsible for executive functions such as planning, impulse control, and working memory, also undergoes remodeling. Chronic stress diminishes dendritic complexity and synaptic density in this region, weakening the brain's capacity for top-down control over behavior and emotion. Consequently, individuals may experience greater difficulty concentrating, impaired decision-making, and reduced cognitive flexibility. This weakening of the prefrontal cortex's regulatory role is often accompanied by hyperactivity in the amygdala, a region implicated in fear processing and threat detection. Under chronic stress, the amygdala tends to become hyper-responsive and structurally hypertrophic, contributing to heightened emotional reactivity, anxiety, and the persistence of negative emotional memories. These changes create a neurobiological feedback loop. Stress enhances amygdala activity, which in turn amplifies hyperaxis output, further accentuating hip cortex dysfunction. Over time, this loop becomes increasingly difficult to disrupt, fostering a state of chronic hyperarousal that can lay the groundwork for affective disorders such as depression, generalized anxiety disorder, and post-traumatic stress disorder. Neuroimaging studies in humans have consistently demonstrated reduced hippocampal and prefrontal cortex volumes in individuals with chronic stress related psychopathologies. Animal models. Beyond structural and functional alterations, chronic stress also modulates neurochemical pathways. Dopaminergic signaling, crucial for reward processing and motivation, becomes dysregulated under sustained stress exposure. This can lead to anhedonia, or the inability to experience pleasure. One of the core symptoms of depression. Similarly, chronic stress elevates glutamate, the brain's primary excitatory neurotransmitter, which in excess can induce excitatory and further neuronal damage. This neurochemical imbalance may also explain the cognitive fog and emotional numbness reported by individuals experiencing burnout or prolonged emotional distress. Moreover, chronic stress affects the brain's immune environment. Glial cells, including microglia and astrocytes, become activated in response to prolonged stress, releasing pro-inflammatory cytokines that contribute to neuroinflammation. This inflammatory response, while initially protective, becomes neurotoxic when sustained, disrupting synaptic function and promoting neurodegenerative processes. There is growing evidence linking chronic stress to the pathogenesis of Alzheimer's disease, in part through stress-induced inflammation and amyloid beta accumulation in the hippocampus and cortex. Interestingly, the impact of chronic stress on the brain is not uniform across individuals, suggesting a role for genetic and epigenetic factors in modulating vulnerability. Variations in genes regulating the serotonin transporter, B-derived neurotrophic factor, and phosphatidylcholine receptor sensitivity have been associated with differential susceptibility to stress-related brain changes and mental health. Early life stress further compounds these effects by programming the axis and brain architecture in ways that increase lifetime risk for stress-related disorders. Despite its profound effects, the brain exhibits a remarkable degree of plasticity, offering hope for recovery. Interventions such as cognitive, behavioral therapy, mindfulness-based stress reduction, physical exercise, and pharmacological treatments can help reverse associated with chronic stress. These approaches may enhance neurogenesis, reduce cortisol levels, and restore balance to disrupted neural networks, emphasizing the importance of early detection and intervention. In conclusion, Chronic stress represents a significant challenge to brain health, disrupting the architecture and function of key neural circuits involved in cognition, in emotion, and motivation. The interplay between hormonal, inflammatory, and neurochemical factors underlies these alterations, with downstream effects on behavior and mental well-being. While chronic stress can inflict lasting damage, the inherent plasticity of the brain offers a pathway to recovery, highlighting the importance of resilience, building, and strategies in preserving cognitive and emotional function. Would you like a version of this, with academic citations and references included? Attention. Deficit hyperactivity disorder. A neurodevelopmental condition characterized by persistent patterns of inattention, hyperactivity, and impulsivity that interfere with functioning or development. It affects approximately 5/7 of children worldwide and often persists into adulthood, manifesting differently across the lifespan. The neuropsychology of ADHD encompasses a range of cognitive, emotional, and behavioral symptoms rooted in atypical brain development and functioning, particularly within neural systems that govern regulation and reward processing. At the cognitive level, individuals with ADHD frequently exhibit deficits in executive functions, which are higher-order processes responsible for organizing, planning, inhibiting inappropriate responses. These impairments are not uniform across all individuals with ADHD, but represent core features in many. Common manifestations include difficulty maintaining focus on tasks that are not immediately stimulating, impulsive decision-making, disorganization, and challenges with time management. These cognitive traits often translate into observable behaviors such as frequent interruptions, poor academic performance, and difficulty adhering to social norms. The neuroanatomical basis of ADHD primarily involves dysfunction in frontostriatal circuitry, particularly the prefrontal cortex, basal ganglia, and their interconnections. The prefrontal cortex, especially the dorsolateral and ventromedial regions, plays a central role in executive control and working memory. Neuroimaging studies consistently reveal reduced activation in these areas during tasks that require sustained attention or inhibition of prepotent responses. Structural imaging has also shown decreased cortical thickness and delayed cortical maturation, particularly in frontal regions, which may underlie the developmental nature of the disorder. The basal ganglia, especially the caudate nucleus and putamen, are implicated in motor control and cognitive processing. In individuals with ADHD, these structures often show volume reductions and abnormal functional connectivity with the prefrontal cortex. These alterations may contribute to both the hyperactive motor behaviors and the cognitive dysregulation seen in ADHD. Furthermore, the cerebellum, traditionally associated with motor coordination, has increasingly been recognized for its role in attention and timing processes. Cerebellar abnormalities, particularly in the vermis, have been observed in populations and may contribute to difficulties in time perception and response regulation. Another crucial neural system implicated in ADHD is the default mode network. Down network of brain regions active during rest and mind wandering but typically suppressed during goal-directed tasks. In ADHD, the DUN shows abnormal deactivation patterns, suggesting that individuals may struggle to suppress internally focused thoughts when attention is required for external tasks. This dysfunction may explain why individuals with ADHD are more prone to distraction and lapses in concentration. In addition to structural and functional brain differences, it is also characterized by alterations in neurotransmitter systems, particularly dopamine and norepinephrine. These catecholamines are critical for modulating attention, motivation, and arousal. Hypoactivity in dopaminergic pathways, particularly those connecting the ventral tegmental area to the prefrontal cortex and striatums of ADHD. This neurochemical basis provides the rationale for pharmacological treatments, such as methylphenidate and amphetamines, which increase synaptic concentrations of dopamine and norepinephrine and help normalize brain activity and attention. Neuropsychological testing in ADHD often reveals specific deficits in tasks measuring working memory, inhibitory control, and cognitive flexibility. For instance, children with ADHD may perform poorly on continuous performance tests, which require sustained attention and rapid responses to specific stimuli. They may also show impairments in go tasks, reflecting difficulties with response inhibition. However, it is important to note that not all individuals with ADHD psychological profile. This heterogeneity has led researchers to propose multiple ADHD subtypes, possibly rooted in distinct neural mechanisms. Emotion regulation is another domain where ADHD individuals show significant challenges. The limbic system, particularly the amygdala, and its connections with the prefrontal cortex, is involved in managing emotional responses. Dysregulation in these circuits may contribute to irritability, mood instability, and heightened emotional reactivity, which are frequently reported and dealt with. These symptoms often complicate social relationships and can exacerbate functional impairments. Recent models of ADHD emphasize the interplay between cognitive and motivational systems. The dual pathway model, for example, proposes that ADHD symptoms arise from both executive function deficits and reward processing abnormalities. Individuals with ADHD may exhibit altered sensitivity to reinforcement, leading to a preference, a phenomenon known as delay aversion. This motivation regulation is thought to be mediated by the mesolimbic dopamine system, further reinforcing the neurochemical underpinnings of the disorder. In summary, the neuropsychology of ADHD reflects complex interactions among cognitive deficits, neural network dysfunction, and neurochemical imbalances. These factors contribute to the hallmark symptoms of inattention, hyperactivity, and impulsivity, as well as associated difficulties with emotion regulation and activation. Understanding the neural basis of ADHD not only enhances diagnostic precision, but also informs the development of targeted treatments and educational interventions that address the suspected individuals. Mood disorders, encompassing major depressive disorder, MIDI, and bipolar disorder, are complex psychiatric conditions characterized by pervasive disturbances in mood, cognition, and behavior. The neuropsychology of these disorders involves intricate interactions among neural circuits, neurotransmitter systems, and cognitive processes. Understanding these interactions is crucial for developing effective interventions and improving patient outcomes. Neuroimaging studies have consistently identified structural and functional abnormalities in specific brain regions associated with mood regulation. In MIDI, hyperactivity in the amygdala and subgenual anterior cingulate cortex correlates with the severity of depressive symptoms. These regions are integral to processing negative emotions and self-referential thoughts. Conversely, hypoactivity in the dorsolateral prefrontal cortex, associated with impaired executive function, contributing to the persistence of negative affect and rumination. Indeed, mood episodes are linked to dysregulation in the prefrontal limbic circuitry, with manic states showing increased activity in the amygdala or prefrontal cortex, leading to heightened inactivity. Neurotransmitter systems play a pivotal role in the pathophysiology of mood disorders. Mood disorders. The monoamine hypothesis posits that deficiencies in serotonin, norepinephrine, and dopamine contribute to depressive symptoms. While this hypothesis has guided pharmacological treatments, recent research highlights the involvement of other neurotransmitters, such as glutamate and gamma-glutamate A, the primary excitatory neurotransmitter, and GABA, the primary inhibitory neurotransmitter, are crucial for maintaining neural homeostasis. Imbalances in these systems can disrupt synaptic plasticity and neural connectivity, leading to mood dysregulation. Moreover, neuropeptides and neurotrophic factors, like brain-derived neurotrophic factor (BDNF), are implicated in the modulation of mood rituals, with decreased attention, with depression and cognitive impairments are central features of mood disorders, affecting domains such as attention, memory, and executive function. These deficits are not merely byproducts of mood symptoms, but are often persistent and contribute to functional impairment. In mid-id, individuals commonly exhibit difficulties in sustaining attention, processing speed, and working memory. These impairments can hinder daily functioning and are predictive of poor treatment outcomes. In BEAD, cognitive deficits are evident across mood states, including euthymia, suggesting trait-like characteristics, executive dysfunction, particularly in planning and inhibitory control, is prominent and may underlie the impulsivity and risk-taking behaviors observed. Tool library. The concept of hot and cold cognition provides a framework for understanding cognitive disturbances in mood disorders. In mood disorder, hot cognition refers to affect-laden processing, such as emotional bias and reward sensitivity, while solving and attention. Mood disorders are characterized by disruptions in both domains. For instance, individuals with depression often exhibit negative cognitive biases, leading to distorted interpretations of information and reinforcing depressive symptoms. In BERD, heightened reward sensitivity during manic episodes can result in poor decision making and impulsivity. So, Neuropsychological assessments are essential tools for evaluating cognitive function in mood disorders. Standardized tests can identify specific deficits and inform treatment plannings. Cognitive remediation therapies aim to improve cognitive functioning through targeted exercises and have shown promise in enhancing attention, memory, and executive function. Additionally, integrating cognitive assessments into routine clinical practice can aid in monitoring disease progression and treatment response. Whispering a link. Emerging treatments targeting neurobiological mechanisms offer new avenues for intervention. For example, ketamine, an NMDA receptor antagonist, has demonstrated rapid latent effects, potentiation of glutamatergic transmission, and enhancement of synaptic plasticity. Similarly, transcranial magnetic stimulation targets specific brain regions, such as the dopamine, to modulate neural activity and alleviate depressive symptoms. These interventions underscore the importance of understanding the neuropsychological underpinnings of mood disorders to develop effective, targeted therapies. In conclusion, the neuropsychology of mood disorders encompasses complex interactions among brain structures, neurotransmitter systems, and cognitive processes. Advancements in neuroimaging and neuropsychological assessment have deepened our understanding of these disorders, highlighting the significance of functional outcomes. Continued research into the neurobiological and cognitive aspects of mood disorders is essential for developing comprehensive treatment strategies and improving the quality of life for affected individuals. Schizophrenia is a complex and chronic psychiatric disorder characterized by disturbances in thought, perception, emotion, and behavior. While the hallmark features, such as hallucinations, delusions, and disorganized thinking, are typically classified as positive symptoms, schizophrenia also encompasses but are often cognitive and predictive long-term functional outcomes. These cognitive impairments are core features of the disorder and can precede the onset of psychosis, persist during periods of remission, and remain relatively stable across the course of the illness. The neuropsychological profile of schizophrenia is broad and heterogeneous, affecting multiple domains, including attention, working memory, executive function, verbal and visual memory, processing speed, and social cognition. One of the most consistently observed deficits is in working memory. The capacity to hold and manipulate information over short periods. This impairment is closely linked to dysfunction in the dorsolateral prefrontal cortex. Neuropsy, a brain region critical for executive control and goal-directed behavior. Functional neuroimaging studies have shown hypoactivation of the Neuropsy during working memory tasks in individuals with schizophrenia, suggesting a fundamental disruption in frontocortical circuitry. Executive function, which encompasses planning, cognitive flexibility, abstract reasoning, and inhibitory control, is also frequently compromised. These deficits can manifest in daily life as disorganized thinking, impaired problem solving, and difficulty adapting to new situations. Tests, such as the Wisconsin card sorting test, often reveal perseverative errors in patients with schizophrenia, reflecting an inability to shift strategies or adjust demands. These impairments are associated not only with frontal lobe dysfunction, but also with disrupted connectivity between the prefrontal cortex and subcortical structures, particularly the thal ganglia. Attention and processing speed are other areas of significant difficulty. Individuals with schizophrenia often display deficits in sustained and selective attention, making it challenging to filter out irrelevant stimuli and maintain focus on goal-relevant tasks. Slowed cognitive processing contributes to a generalized reduction in efficiency, affecting both simple and complex cognitive operations. These limitations hinder academic, occupational, and social functioning, often more than the positive symptoms of the disorder. Memory impairments are also central to the neuropsychological profile of schizophrenia. Verbal memory deficits, especially in encoding and retrieval processes, are commonly reported. Patients may struggle to learn and recall lists of words or recount narratives, even when the comprehension is intact. Visual memory, though less severely affected, can also be impaired. Neuroanatomically, these memory problems have been linked to abnormalities in the hippocampus and surrounding medial temporal lobe structures. Structural MRI studies consistently show reduced hippocampal volume in patients with schizophrenia, and functional imaging reveals aberrant activation during memory tasks. Social cognition, or the ability to perceive, interpret, and respond to social information, is another domain significantly impaired in schizophrenia. Difficulties in theory of mind, emotion recognition, and social perception contribute to interpersonal dysfunction and social withdrawal. These deficits are associated with altered activity in the amygdala, superior temporal sulcus, and medial prefrontal cortex, regions involved in social information processing. Impaired social cognition is particularly important as it mediates the relationship between basic cognitive impairments and real-world functional outcomes. The cognitive deficits observed in schizophrenia are not merely byproducts of psychotic symptoms or medication effects. They are evident even in the prodromal phase of the illness and can be detected in first-degree relatives, suggesting a genetic and neurodevelopmental basis. These impairments also tend to remain stable over time, unlike the fluctuating course of positive symptoms. Importantly, they are among the strongest predictors of functional disability, more so than hallucinations or delusions. Pharmacological treatments, particularly antipsychotic medications, are effective in reducing positive symptoms, but have limited efficacy in improving cognitive deficits. This has led to increased interest in cognitive remediation therapies, which involve structured training exercises aimed at enhancing specific cognitive skills. Some evidence supports modest improvements in attention, memory, and executive function with these interventions, especially when combined with psychosocial rehabilitation. Efforts are also underway to develop pro-cognitive pharmacological agents targeting glutamatergic, cholinergic, or dopaminergic systems, though results to date have been mixed. Understanding the neuropsychology of schizophrenia provides critical insights into the nature of the disorder beyond its more visible symptoms. Cognitive impairments are fundamental to the illness, impacting a wide range of mental processes and contributing significantly to functional disability. These deficits reflect underlying abnormalities in brain structure, function, and connectivity, and require targeted assessment and intervention. As research continues to elucidate the neurocognitive underpinnings of schizophrenia, it holds promise for more comprehensive and effective treatment strategies that address both the symptoms and the consequences of this complex disorder. The amygdala, an almond-shaped cluster of nuclei, located deep within the medial temporal lobes, plays a pivotal role in emotion regulation, serving as a core component of the both circuitry. Long recognized for its involvement in fear processing, the amygdala is now understood to participate in a broad range of emotional functions, including the detection of salient stimuli, emotional responses with cognitive and logical processes, Its role in emotion regulation extends beyond mere reactivity, encompassing both the generation of affective states and their adaptive modulation in social and contextual. Emotion regulation refers to the processes by which individuals influence the type, intensity, duration, and expression of their emotional states. This includes both automatic and effortful strategies, such as reappraisal, suppression, avoidance, and attentional control. The amygdala is particularly engaged during the initial stages of emotion processing, rapidly assessing sensory input for emotional relevance and potential threat. It receives extensive input from sensory cortices and projects to numerous regions, including the hypothalamus, brainstem, and prefrontal cortex, enabling both autonomic and resalient stimuli. One of the most studied aspects of the amygdala's function is its role in fear conditioning. Through its connections with the thalamus and sensory cortices, the amygdala enables organisms to associate neutral cues with aversive outcomes, facilitating rapid learning and survival. This associative learning mechanism is critical not only for immediate threat detection, but also for the formation of memories. Lesion studies in both animals and humans have consistently shown that damage to the amygdala impairs the acquisition and expression of conditioned fear responses, underscoring its necessity for emotional learning. However, the amygdala does not operate in isolation. Its function in emotion regulation is deeply intertwined with interactions with the prefrontal cortex. These cortical areas exert top-down control, overlating its activity in accordance with contextual cues and social norms. For example, during cognitive reappraisal, a strategy that involves reinterpreting a potentially distressing situation to alter its emotional impact, functional imaging studies, and crucial initiation. This reciprocal relationship is central to adaptive emotion regulation, and disruptions in this circuitry are implicated in numerous psychiatric conditions, in mood and anxiety disorders. The regulatory balance between the prefrontal cortex and the amygdala is often disrupted. Hyperactivity of the amygdala has been observed in individuals with generalized anxiety disorder, post-traumatic stress disorder, and major depressive disorder. In these conditions, heightened amygdala responses to negative or ambiguous stimuli can lead to excessive vigilance, rumination, and maladaptive emotional responses. Conversely, Inadequate prefrontal modulation may impair an individual's ability to downregulate emotional arousal, contributing to emotional dysregulation and behavioral symptoms such as avoidance or anhedonia. Moreover, the amygdala's role in emotion extends beyond fear and negative affect. It also responds to positive stimuli and plays a role in social emotions such as trust, embarrassment, and moral judgment and moral. For instance, studies have shown that the amygdala is activated in response to happy faces, rewarding stimuli, and during social evaluations. This broader involvement in emotional salience, rather than just negative valence, positions the amygdala as a key hub in tracking the emotional relevance of both internal and external events. Developmentally, the amygdala exhibits a unique trajectory that influences emotional behavior across the lifespan. It matures earlier than the prefrontal cortex, which may explain heightened emotional reactivity and reduced regulatory control during adolescence. As the prefrontal cortex continues to develop into early adulthood, individuals typically gain improved capacity for emotion regulation. However, early life stress or trauma can alter the developmental course of the amygdala, leading to long-term changes in its volume and functional connectivity. These alterations may predispose individuals to affective disorders later in life, highlighting the importance of environmental factors in shaping emotional neurobiology. Emerging research also suggests that the amygdala may be involved in the interoceptive processing of emotions. That is, the perception and interpretation how they relate to feelings through its connections with the insular and anterior cingulate cortex. The amygdala contributes to the generation of subjective emotional experiences and the regulation of emotional responses. This integrative function supports the notion that emotions are not solely mental states, but embodied processes influenced by physiological and contextual variables. In summary, the amygdala is not merely a trigger for fear, but a dynamic integrator of emotional salience, memory, and regulation. It forms a critical node in a distributed network that balances bottom-up emotional responses with top-down cognitive control. Understanding its role in emotion regulation has profound implications for neuroscience, psychology, and clinical practice, offering insights into the neural mechanisms of resilience, emotional disorders,